Hello, my name is Paul Flynn and welcome to episode 7, The Challenge of Tackling Chronic Pain, part 1. So, up to this point in the podcast, we spent a lot of time trying to understand pain. Now, we started with what normal pain is, why we feel it and how it behaves. We then looked at scans and imaging and why what we see doesn't always match what someone feels. And over the last few episodes, we focused on persistent pain. So we've looked at how pain can change over time, how the system can become more sensitive, and how a range of factors from a person's background and health to the care they receive and the explanations they're given can all influence how pain behaves. And one of the key messages throughout all of this is that persistent pain is not a simple problem. It's not one cause, it's not one structure, and it's very rarely something that can be fixed with a standard form of treatment. So this brings us to the next question. If pain has become persistent, what can we actually do about it? Because managing persistent pain is very different to managing pain where the cause is clear and behaves in a predictable way. And in many areas of medicine, the model is quite clear. There's a problem, it's identified and it's treated. And that might be surgery, medication, or some specific intervention. But persistent pain doesn't fit neatly into that model. And we've already discussed how changes within the nervous system, increased sensitivity, and the way pain is processed all play a role. And because of that, it's not simply a case of switching something off or correcting one issue, because obviously if it was, persistent pain wouldn't be as common as it is, and as a result, we probably wouldn't be having this podcast. And it is common. In the UK, it's estimated around 40% of adults live with some form of ongoing pain, and for many, it becomes something that stays with them over time, rather than something that quickly resolves. So in this episode, we're going to shift focus. Up to now, we've looked at the why. Now we're going to look at the what. What does the evidence actually suggest helps? Not in terms of quick fixes, single treatments, but in terms of approaches that over time can start to move things in a different direction, and a direction that we definitely prefer. Now, one thing that's important to say from the outset is some of the approaches we're going to talk about can seem quite general. Some might seem underwhelming, and some are quite different from what people might expect when they think of medical treatment. If we'd gone straight into these at the very start, it probably wouldn't have made much sense. But when you understand what we've covered in the previous episodes, how pain is processed, how sensitivity develops, and how different factors influence it, these approaches start to make more sense. They become less random and less vague. And what we're actually trying to do here is calm things down over time. Not to fix one thing, but to make the body less reactive, so it's not constantly over-responding to normal movement or activity. And that's really the key idea for this episode. Managing persistent pain is not straightforward. It's not fast, and it's certainly not exact. And it doesn't look like traditional medicine in many cases. It's usually not one big change, but it's a few smaller things that, if done regularly, over time, hopefully start to improve how things feel. So in the next part, we'll start to break that down. What tends to help, what tends not to, and how it all fits in with everything we've already discussed. So, as always, let's jump right in. So, at this point, I want to introduce you to something called the NICE guidelines. Now, some of you may have heard of them, and others won't have. And it's worth explaining what they are, because a lot of what we're going to talk about from here on in comes from them. In the UK, NICE stands for National Institute for Health and Care Excellence. And in simple terms, their role is to look at all the available evidence on the topic. So studies, trials, long-term data, and try to make sense of it in a practical way. So what they look at is what treatment is most likely to help, what probably doesn't help, and what might carry a risk. And they turn that into guidance that's then used across the NHS. So this isn't based on one opinion, one clinician, or one study. It's based on large bodies of research being reviewed, weighed up, with priority given to the strongest and most reliable evidence available. Now, they cover a wide range of conditions, so everything from heart disease, cancer, mental health, musculoskeletal pain, and their guidelines are updated over time as new evidence becomes available. Now, in relation to persistent or chronic pain, these guidelines are relatively recent, so the current version was published in 2021, and while there have been minor updates since then, the overall approach remains more or less the same. Now, if we go back years ago, persistent pain was often approached in a much more traditional medical way. So it was looking for a clear cause. It was trying to fix it, often relying on medication, injections, or various procedures. But as more research developed, largely around the areas that we've discussed, that approach has been questioned. And what we now have is guidance that reflects a different understanding of pain, and one that takes into account of features presented in this podcast. So how pain can become more sensitive, and how behaviour and expectation play a role, and how it changes over time. Now, as we mentioned already, and here's the important part, if we'd gone through this at the very start, it probably wouldn't have landed particularly well. It would have seemed too simplistic. But having worked through the previous episodes, it starts to make an awful lot more sense, and you can start to see where it fits in. And that's what we're going to move into next. We're going to go through each of the guidelines and show how they fit in with everything we've discussed so far, now that we understand pain a lot better. So let's look at the first section, and by far the most important, and that is the concept of education and understanding. Because everything we've gone through up to now, that's not just background, that's not information for the sake of it. It's actually one of the main pillars proposed by NICE guidelines. So if you think back earlier in the series, particularly in episode 1, we talked about what pain actually is. The idea that pain isn't just coming from tissue damage, it's the body's way of protecting you, and in fact it's produced by a signal from the brain itself. Then in episode 3 we took that further. We talked about how that system can become more sensitive over time, and how it can start to react more easily, more quickly, and sometimes more strongly than it needs to. Now, if you take those two ideas, pain as protection and then pain becoming more sensitive, then how you understand pain starts to matter a lot, because following either idea changes what happens next. It changes how you respond to it. So for example, if you think something is damaged, you naturally start protecting it. You move differently, you avoid things, you're more aware of it day to day. But if you understand it's more about how sensitive things have become, you're less likely to react like that. And that's the difference. Even though it seems small, it adds up over time. So we saw another part of the story in episode 6, the role of what people are told and how that shapes things and how they process information. We talked about how the words people hear, the explanations they're given, and even the labels used can shape how serious something feels. So if someone is told something is worn out or out of place or not working properly, it's very hard not to take that literally. And what tends to follow? People again move less, they become more cautious, and they start to work around the pain rather than work through it. And over time that can lead to things not settling, with pain hanging around instead of easing off. Now on the other side of that, when things are explained clearly and people understand what's actually going on, the pattern tends to look quite different. Not because the pain just disappears, but because people start to react differently to it. So they start to move a bit more. They're less on edge about it, and they're not constantly trying to protect the area. And that's where this links back to what we talked about in episode 3. If the system has become more sensitive, then part of what we're trying to do is settle that down again, to turn the volume down and add context, and most importantly, to add fact. And understanding is one of the best ways that starts. Not on its own, but it is a key starting point. Because if someone believes something is damaged or needs to be fixed before they can move, then everything they do tends to follow that line. But if that understanding shifts even slightly, it opens the door for them doing things differently. And this is where the next part comes in, because understanding on its own isn't enough. It has to lead somewhere. What we start to see here is a shift away from trying to fix something and more towards understanding the problem and changing something. It might sound simple, but the distinction between the two words really matters, because if someone doesn't really understand what's going on and doesn't have any sort of direction, they tend to fall back into the same pattern. They stop doing things when something's sore. They avoid certain movements because they associate them as painful, and they wait for the pain to settle before they start doing more. And over time, that just keeps ticking along, and it keeps the sensitivity high. So instead, what's been encouraged here is stepping back a bit and asking, what are we actually trying to work towards? What matters day to day in terms of what we do? And what can we start doing that changes things in a different direction? And at this stage, it's important who you're getting help from. You're looking for someone who understands persistent pain, understands the science behind it, and understands how to approach it properly. Not someone offering quick fixes or single treatments that's going to solve everything, because to the best of our knowledge, that doesn't exist. And what's clear from the guidance is that it isn't just about the patient understanding what's going on, it's also about the person helping them understanding the full picture. You're looking for a person who starts to understand how the pain affects a patient's day-to-day life, what the patient believes is going on. And this is hugely important, because if you don't understand the patient's beliefs, you can't deal with them. What they've been told before, and again this ties in as well, is you need to know what information they've been given, what scans they've had, how they've been interpreted, and how they make sense of all the information they've been given. Because until all of that is understood and properly explained to the patient, it's very difficult to move things forward in a meaningful way. And that's really where the plan starts from. And you listening to this podcast, if you're suffering from chronic or persistent pain, is the start of your journey. And the start of you trying to piece together your journey and potentially some of the factors that influenced it along the way. And there is help out there. So projects like the Better Days programme in Northern Ireland or various pain management programmes spread across the rest of the UK, where the focus is on education and planning. Now, I've put links to these resources in the episode's description, so if you want to have a look. But the education and planning is one of the core messages within the guidelines. And this education leads us on to the next section, and an area that begins to be incorporated into part of the plan. And this section deals with movement. And this is often where people can switch off a bit. Because for a lot of people with ongoing pain, the idea of exercise or physical activity can feel completely out of reach. And it can feel like something that's not possible or not safe or just not realistic at that point. Some can even feel angry by the suggestion, as it can indicate to a person that people don't really understand where they are in their life. And it's important to recognise that, because when we talk about movement here, we're not talking about going out to the gym or start a running programme, couch to 5k, training for a marathon. We're not even talking about going out for a long walk. We're talking about any form of movement. But why? Why are we talking about moving at all? Well, if we strip it right back, let's look at what's actually going on in the body when we actually move, in simple terms, and why it plays a role here. So if you take, say, your joints, for example, your knees, your hips, shoulders, fingers, inside most of those joints, mainly with the exception of the spine, you've got fluid. And this fluid is what's called synovial fluid. Now, the job of the fluid is to help the joint move smoothly, and it reduces friction. So it helps things glide and keeps things moving easier. But here's the key point. That fluid is produced and spread around the joint when you move it. So the more a joint moves, the more fluid is produced and the more efficient the joints move. So if a joint isn't moving, that system slows down and things can start to feel a little bit stiffer and a little bit less smooth. Now, an example of where we see this is actually in ICU. So if a person is unlucky enough to find themselves in ICU and say they maybe have a tube in their throat, it's likely they're going to be sedated and unable to move themselves. Now, in cases like this, on a daily basis, guidance exists that a nurse or a physiotherapist will attend and move the joints of that patient, so their wrists, their knees, their ankles, etc., to maintain the production of this fluid. So joints don't become basically stiff and the friction doesn't increase for when the patient hopefully wakes up. And this daily movement in ICU serves another purpose related to why it's important for everyone to move. So muscles and tissues around your joints, say tendons and ligaments, they're built to move. They're meant to lengthen, shorten and move freely every time we move our limbs. And if they're not being used regularly or not being taken through their full movement that they're designed to do, they can start to feel tighter and become more restricted. And that's when movement can start to feel harder or more uncomfortable than it should. And a really good example of this is if, say, for instance, you break your wrist and you have a cast on for 6 weeks. Now, once the cast comes off, the wrist can feel very, very stiff. And this is generally very, very little to do with the actual fracture. It's mostly to do with the reduced synovial fluid and the shortening of the ligaments and tendons around the joint. And it can take quite a bit of time and work to loosen all that off. So you can see before we even get into the benefits of movement in chronic pain, movement in itself for everybody is essential. And if it's reduced, can bring on feelings of restriction and pain. And there's a simple concept here. The body gets used to doing what you ask it to do. So if you keep the body moving, it tends to stay moving well. If you stop using it as much, things start to feel stiffer, a little bit heavier and a bit harder than they used to. And again, a very simple example of this is, say if we're seated in a car for a long journey. You stand up and everything feels tight for a few steps and then it eases off once you start moving again. And I mean, how many people have you seen getting out of a car, say at a service station on a motorway, and they get out of the car awkwardly, stretch their joints, usually their back and their arms and their shoulders, and everything then gradually loosens off. And this is a perfect indication of the body responding to movement. So once it's loosened off, everything returns to normal, but repeated bouts of this stiffening can result in it taking longer to loosen off. So when we bring this concept back into chronic pain, movement becomes even more important. Because if we're not even doing the basic level of movement, we can start to feel the same aches and stiffness that anybody would. But the difference is how that is experienced and how it's interpreted. Because if you think back to what we discussed in episode 3, where things can become more sensitive, that same stiffness or discomfort can feel stronger, sharper, or more concerning. And it can be taken as a sign of something's wrong. something has been irritated, or something has been damaged. Whereas someone without a background in chronic pain might just stand up, feel a bit tight, move around for a few minutes, and everything settles down. So the same type of feeling can be interpreted very, very differently. And that's where the problem starts. Because if that stiffness is seen as a sign of damage, the natural response is to avoid it, to move less, and to protect it. And that feeds straight back into the cycle we've already talked about. Things feel stiff, movement is avoided, things feel even stiffer, and it becomes harder to break out of that cycle. So this isn't just about movement being good, inverted commas. It's about understanding what you're feeling when you move and not jumping straight to the worst conclusion. And once that starts to shift, it makes it easier to begin moving again. And that's where we start to come into the next part. Because alongside all of this, there are some clear benefits of movement when it comes to persistent pain itself. And this is where movement starts to link directly into persistent pain. Because if we go back again to what we discussed in episode 3, the idea that things become more sensitive, then part of what we're trying to do is settle down, reduce the volume of the nervous system. And one of the ways that happens is through movement. Now, not in a dramatic way, not by pushing through pain or forcing anything, but by gradually showing the body that movement is safe. Because if movement has been avoided for a period of time, the body can start to treat it as something to be cautious about and as a threat. So pain reacts quicker, it reacts more strongly, and it takes less to set things off. So what we're trying to do here is to gently change that. Not all at once, but bit by bit, because as we said, nothing with chronic pain changes quickly. And it has to be slow and progressive. And moving in a way that feels manageable, even if it's only small to begin with, and building that up over time. Because as that happens, the nervous system starts to become less reactive to the slight increase in movement and activity. It learns that it's less of a threat, and it can tolerate it better. So movements that previously felt uncomfortable can start to feel easier. So then we add a little bit more. And it's like trying to trick the nervous system by increasing activity levels by small amounts so it doesn't recognize or react. And this can result in confidence starting to return, and that link between movement and pain begins to change. Now, that doesn't mean that pain disappears dramatically, and it certainly doesn't mean that every movement will feel good. But what we're trying to achieve is things becoming more predictable, less up and down, and less easily triggered. And this shift is really important because once things feel more predictable, people are more willing to keep going and keep pushing. They're more confident to do a bit more rather than stopping every time something feels a bit more painful. And the key here is how small those steps actually are. We're not talking about big jumps or pushing too far. We're talking about small, manageable increases that don't feel threatening. Because again, if you think back to what we discussed earlier, particularly in episode 1 and 3, if we presented a chronic pain patient with a task that feels unachievable, too big of a step or too much of a push, stress levels tend to go up. So things like cortisol increase and the system becomes more alert and more protective. And as we said before, that can increase how strongly pain is felt. So if we set a goal that feels too big or overwhelming, we can actually make things worse. Not because the movement or activity itself is harmful, but because of how it's being interpreted. So it's not just about what the body can handle, it's about keeping the whole system and the person themselves as calm as possible while we build up movement and activity levels. And that's why we're looking for very small, steady increases, something that feels manageable and something that doesn't spike worry and something that can be repeated. And I often ask people in the classes that I take to think about it this way. If in a year's time their pain was maybe 5% less, but they were 20% more active in their day-to-day life, would that sound appealing? Because this would represent a shift, a sign that the system may be settling. And it means progress is actually holding rather than going up and down. And again, this all comes back to what we've already said. This isn't about one thing fixing a problem. It's about gradually helping the system calm and become less sensitive over time. And the starting point of this journey can be any level. So even chair exercises, simply moving your joints, standing and sitting. It's irrelevant the patient's starting point. The concept behind the movement remains the same and is a starting point to start to change the direction of symptoms. So you can start to see that in terms of management strategies, so far we've indicated education, planning and movement. And as we said before, if this was presented to a chronic pain patient in episode 1, most of them would have switched off long ago. Many patients who've had multiple scans, multiple advice, multiple consultations and probably quite a lot of money spent would envisage that this is too simplistic for their problems, too basic for what they're dealing with. But the reason the NICE guidelines allude to these different strategies is because they're steeped in science and evidence that relate directly back to the last 6 episodes and the information we've discussed. And the next point is no different in terms of simplicity, because the NICE guidelines refer to the use of talking therapies. So these are the likes of CBT, which is cognitive behavioural therapy, or ACT, which is acceptance and commitment therapy. So firstly, what are they? CBT is really about looking at how your thoughts, your reactions and your behaviours all link together. So in simple terms, it helps people recognise patterns. So for example, how they think about their pain, how they respond to it, and how that then affects the way they do things day to day. And the aim is to gently shift those patterns. So in the case of pain, not to say that pain isn't real, but to help people respond to it in a way that doesn't keep the cycle going or make things worse over time, along the lines of what we've discussed already. Now, ACT takes a slightly different approach. Instead of trying to control or change the problem directly, it focuses more on helping people live alongside it. So in the case of pain, it's about accepting the pain might be there at times without letting it take over, and then focusing on what the plan is, getting back to doing things that are important for the person, even if the pain is still present. Now, where does this tie in what we've been discussing? So, as mentioned, dealing with chronic pain is not about what you do physically, it's about how you perceive and interpret pain once it's there. Because even with the best understanding and education of pain, and even when you start moving more, pain is still going to be present at times. And what you do in response to that matters. Now, your ability to change your coping strategy doesn't happen overnight. And it's not about ignoring the pain, it's about changing the way you respond to it. And that's where these approaches like talking therapies come in. Their aim isn't to get rid of pain directly, it's to help people understand it better, respond to it differently, and reduce the impact it has on their day-to-day life, which again links back to what we've been saying throughout. This isn't about one treatment fixing the problem, it's about a number of things working together over time, helping the system calm down and become less reactive. So when you take a step back and look at this, you can see why these approaches are included in guidelines. They're not there to treat pain in the traditional sense, they're there because of what we've already talked about. If pain becomes more sensitive, if how it's interpreted and responded to plays a role, then changing that response becomes part of the process. And that's exactly what these approaches are trying to do. So even if we take something like the example of talking therapies, people who've maybe tried these talking therapies and found that they haven't worked, it's possibly because they've never done the background work before that. They've never actually been educated to what their pain actually is. So how can you try and accept and adapt to what happens when you feel pain if you don't even understand in the first place what your pain is? So then you can start to see what we mean by a plan. So initially education on the problem, formulate a plan, start to move more, and develop techniques on how you respond to pain when you move and how you change your narrative and interpretation of the pain. And you can start to see how all of this links back to what we discussed. Now, the next section is actually something that hasn't been touched on up to now, and that is medication. Because this is often what people expect to play the biggest role in relieving pain. But when you look at the evidence, the role of medication in chronic pain is probably not what most people would think. So medication is probably where most people's minds go first when they think about pain. So something is sore, the natural thought is that there must be a tablet, an injection, or some sort of medicine that can settle it down. And to be fair, that makes sense. In a lot of areas of medicine, that's exactly how things work. You have a problem, you take something for it, and the symptoms improve. And when we consider how pain medication generally works, it all makes sense. So most pain medications work by trying to dampen down the signals being sent around the body. So if there's an injury or something is irritated, they can reduce how strongly those signals are sent or received, and that can help settle things in the short term. And that's why they can work quite well in more straightforward short-term pain. But in persistent pain, the situation is a bit different. As we've talked about already, it's often less about one clear signal from one area. It's more about the system being oversensitive overall. So even though medication can still have some effect, it's not really targeting the main issue, which helps explain why the benefit is often limited. Because persistent pain is different, and guidelines and evidence reflect this. Because when NICE looked at the evidence for medication in chronic pain, the list of medicines that they said were ineffective was actually much longer than the list they said to consider. So NICE indicates that to consider certain antidepressants after proper discussion of the risks and benefits have been carried out with the patient. But on the opposite side, they advise against starting things like opioids, so medications like codeine, tramadol, morphine. And they also advise against gabapentoids, so things like gabapentin or pregabalin, which a lot of people will have come across already. And alongside that, they advise against things like anti-inflammatories, paracetamol, and several other medications for this type of pain. And that usually surprises people because many patients with persistent pain have had some of these already or are currently taking them, and many would be forgiven to expect that this would be where the main help would come from. But the reason the guidance goes away from it is the same reason the earlier sections made more sense once we understand the science. And the use of placebos are a really good way of explaining that point. Now, before we go any further, it's worth probably explaining what a placebo is. So a placebo is basically something that looks like a treatment but doesn't actually contain any active medicine. So for example, it might just be a tablet with no real drug in it. And in research, what they'll often do is give one group the actual medication that's being tested and another group the placebo without telling them which one they're getting. And the aim is to assess the effect of the actual drug compared to a placebo, and then they compare the results. And this is where it gets interesting because when researchers look at medications for persistent pain, people taking the placebo often improve as well, which tells us that pain isn't just about medication itself, it's also influenced by expectation, belief, and what someone thinks is going to happen. And overall, there's very little evidence for the use of long-term pain medication when compared to a placebo. So for the likes of medications like opioids, as we said, codeine, tramadol, morphine, or other medications like pregabalin or gabapentin, they didn't find good evidence at all that these help with this type of pain. And over time, there's a real risk of dependence with them. Now, when NICE looked at the evidence, they did find that some antidepressants can help, not just with mood, but also with pain, sleep, and how people are coping day to day. But even then, the benefits aren't huge, and a lot of the research comes from specific groups, like, say, people with fibromyalgia. So when we step back and consider pain medication for chronic pain, this is where the placebo point is actually useful. So when we step back and look at the guidance, it's actually quite clear. For this type of pain, many of the medications people expect to be central, like opioids or gabapentoids, are not recommended to be started. And that's where there's a bit of a disconnect, because a lot of people with ongoing pain are already on these medications, sometimes for long periods of time. Now, that doesn't mean that they should be stopped suddenly or that they've been prescribed incorrectly in every case, but it does raise an important question. If the evidence shows limited benefit for this type of pain, and in some cases shows similar outcomes to actually taking a placebo, then what is actually helping? Is it the drug itself, or is it the expectation around what the drug is doing and the sense that there is an active treatment? And alongside that, there are real risks. So dependence with opioids is well recognised. And with medication like pregabalin, people can experience issues with things like concentration, mood, and feeling generally flat or slowed down. So when you weigh that up, the balance becomes important, because if the benefits are limited, but the risks are real, it starts to explain why the guidance shifts away from medication being the main focus. It broaches the question that pain is influenced by context, expectation, reassurance, fear and attention, and what someone believes is happening, which again takes us back to episode 1, 3 and 6. It doesn't mean that medication is irrelevant, but in chronic primary pain, it's clearly not the main answer people often hope it will be. And that is exactly why guidance places much more weight on understanding, planning, movement, and interpretation of pain. And it's not just medication. There are also treatments that a lot of people will come across that aren't really supported in the treatment of this type of pain. So things like going for repeated injections, or treatments where the focus is on trying to fix one specific part, or going back regularly for treatment that gives short-term relief but doesn't really change anything long-term. And again, when you think about everything we've discussed, that starts to make sense, because as pain has been influenced by sensitivity and how pain is processed by the person, then focusing on one area of the body alone doesn't address what's driving it. It might help for a while, but it doesn't change the bigger picture. So you can start to see this growing trend with all the guidelines. The focus is on sensitivity of the system, not looking for quick, targeted treatment for a specific problem. And the whole narrative we've built up in the last 6 episodes leads to why this hopefully makes sense. Because what we have just discussed are the key pillars of the NICE guidelines, not complicated in how they look, but very much grounded in science, and attempt to offer an actual pathway out of chronic pain. Not suggesting it's all going to be easy, but you can clearly see why education is the cornerstone. These approaches aren't random. They're built around the same ideas we've discussed throughout the series. And from here, we can start to build on it. Because whilst these are the main pillars within the NICE guidelines, they're not the full picture. There are other areas outside of the guidelines where the evidence also suggests we can help. And that's what we're going to explore in the next episode. So until then, take care.